and we'll let people stream in as they do. So good morning, everyone, and happy Friday, happy start of Memorial Day weekend. As the summer approaches, we're facing two novel potential dangers: the avian flu, also known as bird flu, which is afflicting the poultry and dairy industry, not only here in the US, but globally. In the US, the poultry and dairy industry is where many of our immigrant workers are employed. Are there dangers for some of our most vulnerable people in the workforce? A new, more contagious subvariant of COVID is also taking hold. Do our vaccines and diagnostics have the capacity to face KP2 from the FLiRT family of subvariants? Our three esteemed speakers today will discuss both these viruses. Let's welcome Dr. Maurice Pitesky, Associate Professor at the UC Davis School of Veterinary Medicine with a research focus on highly pathogenic avian influenza disease modeling. Dr. Peter Chin Hong, a professor of medicine and the director of the immunocompromised host infectious diseases program at UCSF. And Dr. Benjamin Neuman, professor of biology. Speakers, please speak slowly for our interpreters in Spanish, Mandarin, and Korean. Reporters, we have reserved lots of time today for your questions. Please enter them in the chat and we will get to as many as we can. We begin with Dr. Pitesky, who joins us today from China, where it is currently 2:05 a.m. Dr. Pitesky, thank you for joining us at your early hour. I will start with some questions for you, followed by questions from reporters. So avian flu has been with us since 2012. What accounts for this current surge? Are we seeing surges in other parts of the world?
So just to give you some background, the main reservoir of avian influenza are waterfowl, like ducks and geese. And these birds are migratory by nature, so they can travel literally thousands of miles. And in the summertime, when they're up in the Arctic, that's when they breed. But that's when, because our globe is round, that's when all these birds and all these flyways start interfacing. When you have different versions of avian influenza in different flyways, in the Arctic, for example, the Pacific Flyway, which interfaces with California, where I'm from, those birds interface with avian influenzas from 5 different flyways. And that's how we get this very unique reassortments and combinations. So I would say that we've probably had avian influenzas as long as we've had waterfowl. The thing that's maybe changed a little is that we don't have as much habitat for waterfowl. And that potentially means that when waterfowl migrate into North America, for example, California, where we have a lot of commercial poultry and commercial dairy, they might be roosting and feeding in areas where we have human agriculture, and you're kind of rolling the dice every time you have interactions between wild birds, for example, and domesticated animals such as chickens and dairy cows now.
Interesting. How does the virus spread from birds to cattle, for example?
Yeah, so it's that spatial interface between wild animals and domesticated animals. That's where any kind of transmission can potentially occur. So you could have infected waterfowl when they go to the bathroom, when they have fecal shedding, when they poop, basically. They can shed virus when they're infected, and that virus can stay infectious in their fecal material. Also, they're respiratory effluent. It's a respiratory virus, so they can shed virus as an aerosol. And if that aerosol happens to interface with a domesticated chicken, that's how the virus can spread. There's also the potential, for example, in dairies, one of the things that they found, which is really interesting, is that some of the feral cats around the dairies did test positive for high path AI. So those cats go onto the dairies. So there's other species, not just wild waterfowl, that could act as basically vectors to bring virus in. That's other ways those are the other ways that it can spread. There's also sometimes sharing of equipment. That can, if you have a poultry farm that potentially has some infected material, some of that material can be actually brought over accidentally to some of these dairies, we think. So there's a lot of different routes. And then the other thing you have to realize is that in California, especially, we have a lot of, and in other states, dairies have a lot of lagoons and waterfowl like water. So one of the other ways that we suspect that it's happening is waterfowl are attracted to these man-made habitats that are right around dairies, for example, and some poultry operations.
Absolutely. Reporters, just to note, we are taking questions for Dr. Pitesky in about 4 minutes. So please enter your questions in the chat and we'll try to get to them as many of them as we can. So the next question I have for you, Dr. Pitesky, is you're in China now. Are you seeing a similar spread in China? And I imagine that the industry there is less regulated than what we have in the US. Could you compare the two?
Yeah, so we have this version of HiPath AI on 6 continents right now. This is unprecedented as far as geography, where I do a lot of mapping, and as far as the species affected, both domesticated and wild, both mammal and avian. China is a lot different than the United States in that they vaccinate. There are advantages and disadvantages to vaccinating against highly pathogenic avian influenza. In the United States, we don't vaccinate, and the reason we don't vaccinate, there's a couple of reasons. One is economic / political. We are a major exporter of poultry products, so globally, you're not allowed to export poultry products if you're in a country that vaccinates. The logic on that is starting to change a little. The problem is once you vaccinate, as a lot of us know from our COVID experience, when you vaccinate, you protect against disease, you don't protect against infection. So the reality is we're afraid that you might have asymptomatic spread of the virus. So that's a real challenge. Now, the Chinese is a little more difficult to kind of evaluate, and it's just because I'm not an expert in vaccines and what the Chinese have kind of discovered. But the vaccine can be useful, but it's not as we know with our COVID experience, it's not a panacea. It has to be used thoughtfully. We have to have effective surveillance to make sure we're not kind of under the radar having asymptomatic spread of the virus. I think the reality is we've been dealing with this current outbreak, which is unprecedented since about 2020. And the normal methods of control aren't working. So I think we need to be more innovative. I think we need to think more holistically. And I think we need to think more about wildlife and surveillance of wildlife and really being able to, at the farm level, identify which farms are at highest risk based upon which farms have the highest abundance of waterfowl habitat and waterfowl abundance around them.
Absolutely. So, what does avian flu look like in cattle? Is it also fatal to cattle?
Yeah, so the research on this is relatively new. So they don't call it highly pathogenic avian influenza in cattle because it doesn't cause the same mortality that we see in chickens. So they call it bovine influenza, just semantics, but important semantics. The biggest thing that typically dairies will see is a significant drop in milk production. Dairy cows can become febrile. They can have a reduced appetite. The amount of rumination, sometimes they can measure that with all kinds of sensors, decreases significantly also. So those are the clinical signs that you'll typically see as far as we know at this point. But we won't see the mass mortality that we see in domesticated chickens and in wild birds and wild mammals.
Interesting. I have one final question for you before we move it on to questions from reporters. So a lot of our readers actually work in the poultry and dairy industry. We've got a lot of immigrant workers in those industries. I wonder how vulnerable they are to. I know we only have at this point two known cases of human transmission. Are they more vulnerable? And do you believe the cases are underreported because of the vulnerability of that immigrant population?
Yeah, so first question, I do agree it is an occupational hazard. And I would agree with your second point. Just like all diseases, we have underreporting. We probably have more underreporting in a disease like this because you have a lot of folks that work in this industry where there might be undocumented. The culture is usually to show up to work because you don't get paid if you're sick. So I think it is a unique risk. That being said, I think it's a risk to all of us at some level. There's so much virus floating around. There's a lot of new research that's focusing on virus in wastewater from human wastewater treatment facilities. So that's concerning as far as just how we're finding the virus in the environment, in wildlife and domestic animals. USDA, to their credit, is providing some funding for masks and personal protective equipment and things like that. So that's encouraging to see. The problem is twofold. One, sometimes the culture, it isn't amenable to wearing masks and all the equipment that typically needs to be worn. And second of all, we all know what Texas and some of these other states are like during the summer. Wearing that equipment is probably not a realistic, kind of ask for a lot of these workers because it gets so brutally hot there. And as we all probably know, wearing Tyvek suits and gloves and masks and things like that is extremely challenging in that kind of climate.
Thank you. We're going to move on to questions from reporters. I see a question from Orhan. Excuse me, Orhan. Could you please identify your news organization and ask your question?
Yes, Zaman America. So I have two questions. Basically, since I did cover the bird flu in Turkey a long time ago. So the question is, the animal affected by the virus should be killed? This is the first question. The second question is there any vaccine for the virus, or does anyone work on it, or we already have it?
Yep. So to your first question, one of the best control methods that we have is depopulation of an affected flock, and that's because viruses can't replicate in dead cells. So the big things we have are biosecurity at the farm level, preventing the virus from getting on the farm in the first place. The second thing is quarantining the areas surrounding affected farms to make sure the virus doesn't spread further. And then the third thing is, as you alluded to, is depopulating, euthanizing commercial poultry flocks, and then disposing of that material to prevent any further transmission of the virus. Unfortunately, those are at this point the most effective methods. We don't do that in dairy cows because dairy cows seem to make a full recovery. But we're not sure what happens to the virus. Can it continue to shed? Can a dairy cow that's recovered, can it potentially still shed virus? I think those are questions that we still don't know the answers to. As far as the vaccine goes, there are vaccines that countries do use. Vaccines aren't perfect. When you vaccinate, as I mentioned earlier, it's easy to vaccinate, as I'll tell veterinary students. The hard part's to get immunization. And even when you get immunization, that protects against disease, that doesn't protect against infection. And then the logistical challenge is we have 8 billion broilers in the United States. So vaccinating 8 billion chickens can be very challenging. So we need to kind of triage that based on risk. And then the reality is, from the French experience where they've started vaccinating against ducks, I think in some cases they're vaccinating twice, and they're still getting some clinical signs. So the question becomes, do you vaccinate and still depopulate if you have affected birds? I think those are some of the things we just don't understand the questions to. I think there's a place for vaccination. I think ultimately it's going to be in high risk areas where you have commercial birds that we know are close to waterfowl in high abundance, that we know based on our surveillance are likely reservoirs of high path AI.
Thank you. Our next question comes from Henrietta Burrows. Henrietta, please identify your news organization and ask your question.
Thanks, Sunita. Henrietta Burrows, East Palo Alto today. What are the symptoms of the avian flu, and how might those symptoms differ from those of COVID, for instance? And what are the consequences of contracting it? Is it fatal in humans?
So I'm going to leave that to my human colleagues.
Yeah.
The one thing I will say, though, is that the 1918-1919 pandemic, that was an avian influenza. The Spanish flu or the Kansas flu, depending on how people want to use the terminology. So we know that these flus, these avian influenzas, in the right kind of genetic form, have the potential to be not only infectious to humans, but have the potential to be the source of significant disease and mortality.
Interesting. Our
This
next
virus
question.
at this point is not one of them.
Oh,
sorry.
Interesting. Our next question comes from Selena Rodriguez. Selena. Selena, are you still on?
Yes, I'm here. Can you hear me now?
Yes, we can.
Okay, great. Thank you so much. Selena Rodriguez, Rodriguez Media Productions. And what are the states, doctor, in the USA that are most, where most cases have been registered? And also, what are the ethnic groups that are most affected, please? Thank you.
Good question.
Yeah, so the states that right now the USDA has found the high path AI, the bovine influenza in 9 states and over, I think, about 54 to 58 herds. So mainly in kind of the Mississippi flyway, which is one of the 4 flyways in the continental US where waterfowl migrate. That's probably at some level underreporting because right now the surveillance, the testing that's required by the US in dairies is only required as herds cross state lines. So I would think it's probably in a higher amount of dairy cows and other herds across the US. And that's just my own personal feeling based upon just my own hunches and how the dairy kind of herds are moving around. In birds and commercial poultry, we have most of our commercial poultry in the Midwest, but we've found the virus in wild birds across the entire continental United States, across the entire world. So we've had commercial poultry affected in multiple locations. Basically in every state in the US except for Hawaii at this point. So it's ubiquitous. And then as far as I think was your second question about who is disproportionately affected by this?
Yes, please. Yes, please. What is the race most affected? What are the ethnic groups that are most affected, please?
So I think, when you look at the folks that work in poultry plants, poultry farms, dairy farms, those are typically immigrants. It's very hard physical work, as I think we're all somewhat aware of. So there is an occupational risk for that population, and it's very challenging work. Now, the one thing I will say is there are some interesting technological solutions. The dairy industry, to their credit, has adopted the milking machines and the robots that do that work. There's still a lot of human risk, though, to your point. And as I mentioned earlier, I think it's sometimes not really viable to ask those workers in those poultry houses and in those dairy operations to wear personal protective equipment in the summertime, for example.
Thank you very much.
Dr. Pitesky, before we let you go to get some sleep, could you leave us with your 30-second soundbite? What is the most important takeaway you would like our reporters to grasp from your remarks here?
Yeah, I think the biggest thing that I kind of think about is that we've domesticated livestock for 7 to 10,000 years. We've never had anything like this geographically or with respect to the wide number of species affected. Once viruses jump from avian to mammals, that's concerning. And this virus has shown a remarkable ability to move into various species. Poultry is right now the #1 consumed animal protein on the planet. It's relatively inexpensive and healthy. What we're dealing with right now is an existential issue to the poultry industry globally. It's so important if we're going to feed 2 billion more people in the next few decades. Poultry is probably part of that solution. And if we can't get a good handle on this, I'm afraid that that's going to be a real challenge for us to do on the food security side. And food security is really, really important for global stability and for all of us to be able to thrive. So I'm concerned just from a food security side, let alone from this potential for another pandemic.
Thank you so much for joining us. Very much appreciate your comments, and we'll let you get some sleep.
Great, thank you. Thanks, everyone.
Thank you. Yes, we now move on to a panel discussion with two familiar faces, Dr. Peter Chin Hong of UCSF and Dr. Benjamin Neuman, from Texas A&M. I will ask a few questions to kick us off, and then we'll move on to Q&A. Reporters, please enter your questions in the chat, and again, we'll try to get to as many of them as we can. So we'll start off with Dr. Chin Hong. Dr. Chin Hong, do you expect to see more cases of bird flu in humans as we move on?
Yes, definitely. In the last 30 years or so, we've already had about 880 cases in humans with about a 50% fatality rate. But with this current, series of cases in dairy cows, the bovine influenza, we've had 2 confirmed human cases. They were both conjunctivitis or red eye, essentially. And there are anecdotal reports of many dairy workers actually going to community clinicians who didn't really expect that to possibly be influenza. So they didn't undergo testing. I think they just got eye ointment. So there are probably a lot more cases than we know for many of the reasons that Dr. Pitesky outlined. And we would expect many more. I think in this current state, it doesn't seem to be that pathogenic in humans, at least in the 2 cases we know about. If it continues to evolve, it may cause more serious disease, like in the cases in the last 20 to 30 years around the world. So, I think to me, it's not a matter of if, but when it will happen, just because, we've been seeing species creep wildfowl to mammals, and now to chickens and cattle. We already know dogs and cats can get infected.
Yeah, you spoke about this a little bit, but what does avian flu look like in humans? And can workers in poultry and dairy get sick just from being around infected animals, or how do they actually catch the disease?
So generically, what we've known about avian flu, this particular one, H5N1, in the global experience is that it's very, very deadly, and it appears like a regular bad flu, except that the fatality rate is higher. And just like early COVID, it's mainly a respiratory disease and difficulty breathing. But what we've seen in the 2 reported cases last month in Texas and just 2 days ago reported from Michigan is that they were really coming in with just red eyes, and they got better very quickly. There was another case in Colorado from someone who was working on a poultry farm, also with H5N1, that person just really had fatigue. So at least in these cases right now, they don't just seem to be that serious. But again, given the history of this particular organism, given the role of avian flu in previous flu pandemics in humans, 1918 and several other flu pandemics around the world initially came in from birds. And the reason why it's so deadly initially in humans is because we're not used to seeing this kind of infection. It's almost like the early days of COVID. So we don't have the necessary immune system to target it. But the difference right now is that, and we can get into this, is that we do have a candidate vaccine, we do have therapy, we know how to diagnose it. So it's different in some senses from early COVID.
Interesting. I'm going to ask you the same question I asked Dr. Pitesky, just because it's so important for our audiences. Do you believe there is an underreporting of cases because of the vulnerability of immigrant workers who are largely in these industries?
100%. I think the 2 cases we know about is just the tip of the iceberg. We don't even know how many people have asymptomatic infection. Usually with influenza, it doesn't usually cause an asymptomatic infection. When you get it, you get it. And it's very high conversion rate, unlike COVID. But we just don't know about this instance because it's been very difficult for multiple reasons to have farm workers submit samples, even when people from the CDC and others have gone in. And they're due to a few factors. I think some of them have already been outlined. There's probably, remember in COVID with essential workers, having sick leave was really, really important, and paid sick leave. Not when people show up, they get paid. So that's really the current culture in these dairy farms. The second is immigration amnesty. Many of these workers are, probably undocumented. So there's fear of deportation. So if there was some regulation around immigration amnesty, I think it will help all of us. And that's my whole point. And then the third is income assurance, which is related to sick leave. The fact not only do workers will get compensated even if they're sick and they don't come into work, or if they were diagnosed but had no symptoms, but also poultry farms, or cattle farms, there's probably a fear that if you diagnose a bunch of people with infection, even if they have no symptoms, you may have to shut down that farm for some time. And the federal government has responded somewhat to that by providing, I think, something in the order of some money. I think maybe $50,000 is something per dairy farm, but in my estimation, it's probably not enough. So these are all the barriers that we have to face in addition to access to healthcare. Some of the same things we talked about COVID, linguistic differences in the population, education, and just fear.
Yeah, absolutely. Are humans going to get sick from drinking infected milk or eating infected beef? There's been a lot of, I think, misinformation and disinformation around that. So could you please clear some of that up?
Yeah, so many people might have heard that a week or 2 ago, there was reports that 1 in 5 milk samples around the country, on average, were found to have fragments of H5N1 influenza. So a few things about that. First of all, they were fragments. They weren't whole virus. They were just chopped up pieces. And in fact, the CDC did work, and some other people, by taking some of these fragments and putting it into chicken and eggs, really, which is kind of to see if they would come back alive. And they didn't. So the process of pasteurization, which is heating the milk at very high temperatures for a short period of time, which we expect did seem to kill this particular virus as well. And the second thing is we don't have assurance about raw milk or cheese made from raw unpasteurized milk. In fact, today, there was a report in the New England Journal of Medicine showing that in a mouse model, when the mice were given milk from infected cows with H5N1, it left the gut and actually went to the lungs and caused them to be very sick. So at least in proof of principle, we know that if someone were to drink raw milk, and in this study, they also kept the milk in the refrigerator for several days and it was still viable, which is not surprising, that it could be potentially at risk. And what the 1 in 5 samples showed is that, like what Dr. Pitesky said, right now we only test animals when they go across state lines, but it's kind of foolhardy because the virus doesn't respect the border of the state. So there are probably a lot more infected cows. And right now the pasteurization process is killing the virus, but it may be more widespread than people think.
Let me ask you one additional question. What additional regulations does the FDA or OSHA need to put in place?
I think that's a really great question. I think it's really tough because you want to preserve people's livelihood, but also want to protect people. So, of course, in a more extreme case, you can imagine like a COVID situation where you have to have regulations around personal protective equipment, PPE, having it available for people. I think that's the minimum. But also, I think that's probably not enough. And you have to think about some of the other things we talked about, like sick leave or income assurance, immigration status amnesty, at least for this period of time. But from an OSHA perspective for protection of workers, one thought is, the government did approve the production of 4.8 million doses of vaccine. So one idea is that's obviously not enough for the 333 million people in the United States. But can you imagine prioritizing dairy workers as well as the elderly and probably the very young, which we'll think in influenza, as the groups potentially most effective, but probably the first priority would be the dairy workers, and that could be part of protective regulation that can help keep them safe.
Thank you. We're going to have questions from you, for you from reporters. Reporters, please enter your questions in the chat, and after we have a few questions for Dr. Neuman, we will start with your questions. Dr. Neuman, we're going to move on to COVID. Could you please describe the characteristics of KP2, which comes from the FLiRT subvariant of, I believe it's the Omicron variant, is that correct?
That's correct. Yeah, this is a new name for a very old thing. The name FLiRT, capital FL, lowercase I, capital RT, comes from two particular mutations that have been seen in this strain. These are both mutations that are common. And the mutations, we're talking about a change in amino acids. And so there's an amino acid that was F that turns into an L and an R that turns into a T. I don't think the details are particularly interesting for your readers, but that's where it comes from. These are adaptive mutations that have popped up on several different lines, and so they seem to be recurring, and they seem to give the virus a little boost. There are pretty good statistical models now for predicting the characteristics of a new strain when we only have its sequence information. For example, we can predict quite reliably how well this virus will grow, how well it will be able to evade immunity, and how well it will be able to compete with other versions of the COVID virus, SARS-CoV-2, in order to sort of gain market share in the human lung. And this is an interesting strain. So the FLiRT variants, which are from KP2, and there's also KP3 and several subtypes in there. These are not better adapted at grabbing on to human cells. So they are no better than their ancestors at binding to us. Where they excel is they have a lot of mutations, the most we've ever seen, that are sort of concentrating all the mutations for fast growth and high competitive growth. This is one of the more aggressive versions of the virus that we have ever seen. As well, this is at the top of the scale in terms of immune resistance, which means that it will almost certainly be able to infect people even if they have been recently vaccinated, although recent vaccination still remains very much the best way to not die from the virus. So there's some chance of infection breakthrough, but vaccination does top up the immunity that would be protective. Now, the FDA was scheduled to meet a little over a week ago to decide on the new strain for this fall's COVID vaccine. They postponed that meeting for another few weeks. It's next month now. And the reason that they gave for postponing was that they wanted to see how the situation would settle out, essentially, which variants they should choose for the upcoming vaccine. The plan, according to that website, is still to roll out the new vaccine for the fall. In the past, there have been proposals to that FDA panel to update the vaccine twice a year, which would, in my opinion, do a lot to prevent infections and give people the option of taking 2 doses a year as opposed to 1. However, that does not appear to be the path that they are taking right now. It appears to be a once annual vaccination, sort of in the back to school and winter season, when we know that this is a virus that occurs sporadically and peaks at different times throughout the year, every year. It's essentially unpredictable. So we're treating COVID as if it were flu, even though it's very much not. That's kind of where we are on that.
Yeah.
Extra details, if you like, on the bird flu. There are 2 strains of H5N1, the high pathogenicity version, that are circulating in the world. The main one that is causing all the problems in cows and cats and chickens across the world right now is called 2.3.4.4b. 2344b.
Okay.
There is a second strain that has been found in Southeast Asia, particularly in Vietnam. That one has not jumped over to humans, but it is causing problems in farmed poultry. And one other thing about the high pathogenicity flu virus. So one difference between this and some of the normal flu is that human adapted flu tends to be very efficient at the way it enters and exits the cells in our lungs. So it will come in at the top side of the lungs. There are projections that look like little fingers on the top. And that's the surface that we use to breathe. It comes in that side, replicates, and then goes right back out the same side. And so you end up breathing the flu out and infecting someone else. Some of these exotic flus that are coming over from birds in particular, which are the reservoir for most types of flu, are a little less efficient at this. And so in some people, unpredictably, the virus sometimes doesn't come in from the top and go back out the top. It sometimes comes in the top and goes out the sides and the bottom, which leads to infections in unusual places. When you're talking about fatal cases, it tends to be something like encephalitis, like an infection in the brain and an immune response to that infection. And it's all started out by the virus essentially following the wrong sign or going in the wrong direction. So there are mutations that we know of from laboratory work that would make the H5N1 potentially more adapted to grow in humans. Those mutations are not circulating in the wild strains right now, but in experimental settings, when people have infected pigs, for example, they find that some small amount of those human favored mutations do show up. So there is certainly risk, and I would agree with the other two doctors on this call that this very much bears watching.
Absolutely. So let me ask this question of both of you, Dr. Chin Hong and Dr. Neuman. Do you expect something like a COVID pandemic to be associated with avian flu in humans?
I can start off. I think that it is possible that we can have a pandemic. The last several flu pandemics, when you think starting with 1918, have originated as avian flu. But it's probably going to be hopefully land a little softer because we have a diagnostic test for it. We have at least 4 drugs for flu right now. We have at least 2 candidate vaccines and potentially the use of mRNA vaccines. But the devil is always in the details. And even though we might have the building blocks, the implementation and the flow of these, therapies and diagnostic tests to the average person is really going to be difficult, like it was in COVID. And then we have to talk about the global community as well. So I think all of these things will still make it challenging. But I think that at some point, many people do believe that we will get a pandemic. It may not be right now with what's going on in the dairy cattle, but at some point in the medium term, I would say we would be at risk for getting one.
Wow. Dr. Neuman, do you want to take that question on? That is very alarming, Dr. Chin Hong.
Yeah, I certainly hope we won't see a pandemic of high pathogenicity flu. But wherever the virus grows, the virus can change and the virus can adapt. And change is unpredictable. A virologist's job is not to tell a virus what it can and can't do. We've seen people try that in the past, and it does not go well. Keep an open mind, look at the possibilities, and this is potentially one of the worrying viruses that are out there. We live in a world of near misses that would be frankly shocking to most people if they knew about them, and that's just the function of our immune system. It cleans up a lot of potential problems before we notice them. And the ones that get through are always exceptional in some way, unusual. It's never certain whether they're going to be reproducible, whether they're going to spread widely once they've made one leap. But you always have to, I would say never count out viruses when it comes to spreading.
Thank you. Renee Barbie has a question for you, Dr. Neuman. Renee, could you please ask your question and identify your news organization?
Thank you. Dr. Neuman, why do we continue to get new variants after nearly 4 years of COVID-19? Also, will the public need to have another vaccine for these new variants?
So there are a couple answers to your question, and it's a good one. We get new variants because we choose to name them, but whenever the virus grows, the virus changes. This is a thing you run into in the laboratory. You start with one virus, grow it for a day or two, and it will be slightly different after that. And that's exactly what happens inside of every person. But in people, it's multiplied by the fact that we have an immune system, which is learning to recognize the virus and kills off all the viruses it can recognize. And so this pushes the virus to change possibly a little faster than it would otherwise if we had no immune system. So as long as there is COVID, there will be new variants. We've stopped, or the WHO has stopped naming official variants. All of these new ones are still just Omicron, according to them, which is fine. But there are changes, and the changes do have an impact on how our immune system would see them. So it would be important, I would say, to get the updated vaccine as soon as it's available. And right now, the uptake of the last version, the current version of the vaccine, is very low in the US. And so there are still a lot of people who would benefit from that. It may not prevent infection completely, but it is very much the best hedge against dying of COVID, which is a thing that still happens. If I remember correctly, I think we're still burying about 500 people per week in the US from COVID.
Thank you. Very sad.
Yeah. Dr. Neuman, to follow up on Renee's question, what about the diagnostics, right? Those old test kits that we've got lying around in our kitchen drawers, are those still effective at diagnosing KP2?
In theory, yes.
Okay.
Will probably be out of date. And so that means that they may miss some of the time, but the tests work based on detecting parts of the virus that have not been changing very much in the recent evolution. So in theory, yeah, they would still work. Although if you have a chance to freshen your stock, I think that's probably a good idea.
Thank you. Dr. Chin Hong, here's a question for you. Public trust has declined in the CDC and in public health overall. How do we rebuild trust as we monitor bird flu and new variants of COVID? And Dr. Neuman, you are free to answer that question as well, if you'd like.
I think it's really difficult. This idea that health and science has been intertwined with politics. Even right now, there's a big aligning of whether or not raw milk is a right versus, the whole idea that it could be potentially dangerous for some people, which is kind of a scientific issue, but it's been being deployed now as a political issue. So that's really troubling to me, because when I wear a mask in the hospital, it's not because I have a particular political affiliation, but that's what it's become in many parts of the United States, unfortunately. So what can you do about that? I think there's no easy answer, but continue to have conversations with people and meet people where they are. And, for example, in COVID, even if somebody doesn't want to be vaccinated, I can still offer them therapy if they're at high risk and they got ill with Paxlovid or something like that. So I think there may be different strokes for different folks. And I think being flexible about where people are is probably going to be the first step, and having curiosity and humble inquiry about why somebody might be in a certain position. And usually the person isn't in a fixed position. So I never really try to be dogmatic with people. But in terms of a federal agency and public health, it's very challenging right now. And I'll just end with the fact that, we don't have a national health system. We don't have a national health information system. And the CDC doesn't have power to collect data from jurisdictions. In fact, on May 1st, as you know, hospitals are not required to report COVID hospitalizations anymore. And the CDC can't even mandate farms to give data around avian flu. So, there are limitations in our system that also doesn't make it easy to kind of have the best foot forward. But I would say that in general, though, I've noticed that as a clinician, the CDC is taking more of a leading role, and I think, to me, more trusted than the early days of COVID with avian flu. So I'm hopeful that, things will change.
What about you, Dr. Neuman? Would you like to take that question on?
So I'm not in public health, and I shouldn't be putting words in their mouths. I can tell you that the way I see it, my work is funded by the public, directly or indirectly. And so the way the social contract works is that I don't get to make policy decisions, and I don't get to tell anybody what to do or think. I try to do my best to get expert answers to questions when people have them. And it's frustrating, but ultimately, I think that's probably the only ethical way that I can think of to operate here.
Thank you. Two questions for you, Dr. Chin Hong. Elena Kuzitsnova asked the next question. Elena, identify your news organization and please ask your question.
Hello, everybody. Yeah, I'm here. Hello, everybody. So my question is, are there any high risks of getting infections, diseases from mosquitoes this summer? Should we expect anything? Thank you.
Those are great questions, Elena. In terms of mosquito-borne diseases in the United States, the main one is West Nile virus, which, again, over the last few years has spread across the United States now, and it's usually a summer infection. Most people are asymptomatic, about 90%, but about 10% of people will get flu-like illness, and about 5% or less will get serious brain infections. So I think it's important to protect against mosquitoes. With that said, because of climate change, we are seeing new threats in the United States. We had malaria in Texas. One case that was not thought to be imported. We've had cases of chikungunya close by, Zika virus. So these continue to be threats. And of course, dengue is moving into new territory. Most is still imported, but there has been a case in California early in the year that was thought not to be imported. And the kinds of mosquitoes that we have floating around could become infected, and as it gets warmer, they could spread some of these illnesses. But right now, I think it's mainly West Nile for your average person.
Fantastic. So, Dr. Chin Hong, here's another question for you. Hospitalization rates from COVID are currently fairly low. Do you expect them to surge this summer?
Yes, I mean, it's not going to be like the winter. So the way I think about it is like if you think about the winter, like a surge per se, although the surges have been getting lower over the years, the summer is like a swell. As a few things. First of all, immunity wears, and it wears off fastest in those who are older and immune compromised. And as more people get infected for the reasons that Dr. Neuman outlined with the new variants, it'll just be easier to get it in a more vulnerable state. And because of low vaccination rate and low uptake of Paxlovid still, I'm worried that we'll get a swell in hospitalizations, but it wouldn't cripple hospitals, in my opinion, this summer, but we can still have an impact on that. And the third reason is, of course, as we get warmer temperatures and through climate change and other things, people are gathering more and more indoors now, and that is almost like winter. So I think those are also reasons why we would expect a swell or a little bump in the summer. We've had 4 consecutive summers of COVID increases, so we expect the same. It's coming a little bit earlier this year from the wastewater analysis in California. We know that the wastewater has gone up already by 82%, but the hospitalizations and deaths are remaining fairly low. But wastewater always goes up first before it affects humans. Last year was about late June that the wastewater started going up. So for whatever that's worth, I think it means that we need to encourage, particularly those who are vulnerable, and especially if they didn't get a vaccine last year, to please go ahead and get it. And if you don't want to get a vaccine, make sure you know how to get access to early therapy if you get COVID.
Thank you. Dr. Neuman, we always ask you to forecast what's on your radar for the future. What variants of concern are you looking at?
Right now, it seems to be mostly JN1 and its descendants out there. And those are different enough from any of the strains that have been circulating in the last 2 years, really, that there would be very little neutralizing immunity. That's the type of immunity that would stop a person from getting infected. Certainly, most of the cases that are out there are of one of those two variants right now. I think that's around 90% of what we see. There are a few fringe variants that seem to be rising, but they're in fairly small numbers right now. And I really suspect that the next big strain will come out of this current crop. Although, like I said before, it's not my job to tell the virus what to do. And this is a very hard to predict virus. The only thing we can say for sure is that it should be a descendant of the current Omicron strains that are out there right now, whatever that means.
All right. I have a question for both of you, and then we'll get your 30-second sound bites. Masking continues to be a contentious issue. Are both of you still wearing masks in public spaces? And how would you advise your families and this audience? Dr. Neuman.
Sure. Yeah. I carry a mask in my bag, and it's whenever I notice somebody who's sniffing or who has a tissue or something like that, I put it on for sure. But no, I'm not wearing it as much as I think I ought to. But every time I see somebody out there with a mask on, even if it's because they're sick, it makes me feel a whole lot better, and I smile a little bit on the inside. I don't want to make them feel weird, but it's a really nice thing to see.
Great. Dr. Chin Hung.
I love Dr. Neuman's approach of not really only linking masking to COVID protection, but it's really good for everything that's respiratory spread. And I wish that it would become more ingrained in our culture, particularly around wintertime, but also as the numbers go up. For me personally, I'm not wearing a mask regularly anymore, but I do carry it around all the time. And I'm just watching the numbers very closely. So of course, if the threshold goes up or the threshold goes lower for me to wear that mask, I have no problems in pulling it out. I'm not worried that I'll get very sick. I've been up to date on vaccines, etc. But I'm worried about protecting others around me who might be more vulnerable, like my elderly family. But also, I don't want to have my plans disrupted. I'm hoping that I can travel this summer. And I think, you know, when you pack your first aid kit to go abroad, carrying diagnostic tests and masks should be part of everyone's arsenal right now.
Fantastic. I'd like to get each of your 30-second sound bites. What are the most important takeaways you want our reporters to hear from you? Dr. Chin Hung.
Well, I would say that my soundbite is that emerging threats will continue our lifetimes, and we have to keep our efforts laser focused on protecting all parts of our society, especially the vulnerable, and given our fractured healthcare system. And what that means is that we have to continue to invest in and advocate for legislators to invest in public health. There's been a 50%, people quitting jobs in public health over the last few years during COVID, and we need tens of thousands of people still. And prevention is never sexy, but remember, if you don't see something, it means that it's a success of prevention, not the reverse. So that's my thought.
Thank you. Dr. Neuman.
Yes, I was just typing a response to Henry. It's an unpredictable world out there, and I like that we are seeing so much surveillance. There definitely could be more, but I feel like we are picking up some things now that we would have missed a few years ago, because people are a little more attuned to watch out for mystery sniffles and coughs and pink eyes and things like that. All the same, if there's something unusual, we have the tools now, and they're fairly widespread. Your local doctor probably has a way to get a sample to a lab where they can actually get a diagnosis. You don't have to say, well, I feel like I have the flu anymore. You can actually find out. And that's kind of neat and very good, I think, in terms of public health. So stay vigilant. Yeah, take the vaccines when you can, if that's all right with you. It certainly would mean a lot to me and to everybody else around you. We're all in this together, absolutely. And yeah, stay safe.
Thank you. Thank you both for a really robust and engaging conversation. We already have questions in the chat, so we could continue on with this conversation for a good long time, but we really appreciate your time today. Thank you again. And thank you to our reporters. See you next Friday.